Good evening to everyone and welcome to today's wonderful evening. Thank you, Dr. Kulsum and Dr. Sushant, for coming to the class. Our regular benchmates and batchmates, Girija, Sai, they're all on a mass leave to Karnal for a break. So students have a choice to take a break, but as a teacher, I have no choice because most likely date of NEET PG will be somewhere in January 2nd or 3rd week. Everything we should finish by November 30th. So from now, November 30th, we have 60 plus 25, 85 days. Even if we do 3 hours revision every day, another 250 hours. And let us not miss the bus and all the remaining 30,000 facts we try to revise in the next 85 days. So that is the whole idea. So please do come another 3-4 days before our gang will be back. Until then, I need to, if you want, I will send a Mercedes Benz to pick you up from your home to come to the class. So with that preamble, let's make the great beginning, Doctor. So acid-base disturbances is always an enigma for a lot of students. One tricky point you need to remember is carbon dioxide is not a gas. Carbon dioxide is acid. Because carbon dioxide combines with water to form carbonic acid, and that in turn will release the H plus ion. So carbon dioxide is nothing but acid. So whenever the body develops metabolic acidosis, How will you identify metabolic acidosis with decreased bicarb? Whenever body develops metabolic acidosis with a decreased bicarb, the respiratory compensation is by creating respiratory alkalosis. That means the carbon dioxide, which is the acid, need to come down. So metabolic acidosis is characterized by decreased bicarb, and respiratory compensation is by decreased carbon dioxide. Similarly, metabolic acidosis, metabolic alkalosis is characterized by increased bicarb, that is compensated by respiratory acidosis, which is by increased PCO2. Till here you understood? Because CO2 is nothing but acid. You want to create respiratory acidosis means increase acid, increase PCO2. If you want to create respiratory alkalosis means decreased acid, decreased PCO2 is what you need to understand. So when you have metabolic acidosis, respiratory alkalosis is the compensation. And to do that, PCO2 is decreased. Whenever you have metabolic alkalosis, compensate with respiratory acidosis, that is by increasing the PCO2. This much clear? No doubt? Now, for every given bicarb value, there is some expected PCO2. So the measured PCO2 is equal to predicted PCO2. That means it is a pure metabolic acidosis. But if the measured PCO2 is more than the predicted PCO2 means, there is something else adding the acid in addition to metabolic acidosis. And what is that adding that acid? Respiratory acidosis is adding. If the measured PCO2 is less than the predicted PCO2, that means there is something other than respiratory alkalosis, respiratory compensation, which is adding to the alkalosis. That is possible only if there is an associated respiratory alkalosis with the given metabolic acidosis is what you need to remember. So that is the importance of Winter's formula. Good to see Ibiabuchi and many more. Now, renal tubular acidosis, one of the favorite topic of the examiner. What is the purpose of kidney? The purpose of kidney is to eliminate the acid from the body. How will kidney eliminate the acid from the body? What is the mechanism? One method is kidney reabsorbs the bicarbonate in the proximal convoluted tubule. Second, kidney secretes the H plus ion at the collecting duct is another way it will wash out the acid into the urine. Two methods. So when will acidosis happen? Because of the renal dysfunction, renal tubular dysfunction, either the proximal tubule fail to reabsorb the bicarb or the distal convoluted fail to secrete the acid. When the proximal convoluted tubule dysfunction is there, that is called renal tubular acidosis type 2. That is the sad part. These fellows who create nomenclature, वो नीचे से ऊपर देखता है, ऊपर से नीचे नहीं देखता. The renal tubular acidosis, because of the distal renal tubular dysfunction, is called renal tubular acidosis type 1 is what you have to emphatically remember for the tomorrow's exam. Good to see Girija. and many more who are all online. So it is impossible to teach and it is impossible to learn remotely. At least if the students are remote, teacher should be in the class with face-to-face students. So, doctor, Dr. Joshi Sugandh Kondepagu. Nice to see you, doctor. Every day, please attend the live class. Every day we discuss together 3 hours. Now, doctor, in the distal renal tubular acidosis type 1, which is a distal, it is the alpha intercalated cells which are supposed to secrete the H+. They are unable to secrete, and that lead to development of metabolic acidosis. Because of that, how will be the urine pH? Urine pH will be less. Suppose expected to be less than 5.5. But still, did the proximal tubule has a capacity to compensate that? Yes, right? So it is still compensatable because proximal tubule is still functioning. Then how will be serum potassium in this? Every time there is an acidosis in the blood, there are 2 things. One is H+, other is K+. There is a competition between H+ and K+ to be reabsorbed. If H+ is too much reabsorbed and leading to acidosis, K+ will be lost into urine. That's the reason they develop hypokalemia. Serum K+ is low. Now, what lead to distal renal tubular acidosis? We give a lot of analgesics to the patients. Analgesic nephropathy, amphotericin B toxicity, and any congenital anomalies of urinary tract, SLE, all these typically happen whenever there is distal renal tubular acidosis. Distal renal tubular acidosis patients have a problem and an increased risk of calcium phosphate kidney stones. Why? Because whenever the acidosis is there is an increased bone turnover, because the bone need to undergo turnover and need to release the phosphate in order to compensate that acidosis. That's the reason all that excess phosphate lead to development of calcium phosphate kidney stones is what we need to remember. So distal renal tubular acidosis is associated with calcium phosphate kidney stones because all the acidosis cause a increased bone turnover, and that lead to development of the calcium phosphate stones is what you need to understand. So you can see, doctor, proximal tubule, thick ascending limb, alpha intercalated cell and beta intercalated cell. Earlier we discussed. What happens in proximal tubule, doctor? Sodium moves in, H+ moves in. H+ moves out, sodium moves in. And to move this H+, there is a H+ ATPase which is available in proximal tubule. Then this H+ binds with bicarbonate to form carbonic acid, which will cause carbon dioxide to form by the action of the carbonic anhydrase, and that carbon dioxide diffuses, and once more that converts into bicarbonate, and that bicarbonate is ultimately reabsorbed. So this is an ongoing process that happens in the proximal tubule, which mainly helps to reabsorb the bicarbonate back into our body and lose the H plus in the process. But H plus secretion is not the main function of the proximal tubule. Its main function is bicarbonate reabsorption is its main theme. Whereas if you take alpha intercalated cell in the distal convoluted tube, in the collecting duct, H plus moves out, K plus moves in, and in turn once more the K plus moves back. And this H plus secretion is one of the main mechanism by which alpha intercalated cell of the collecting duct basically helps to get rid of the acid from the body, is what you need to remember. So this explains the whole story of renal tubular acidosis. Once there is distal renal tubular acidosis, intercalated cells are unable to secrete the H plus. That's the reason all H plus comes and stays in the blood. When there is a lot of H plus in the blood, there is an acidosis, then bicarbonate in the blood become consumed. If the bicarbonate is being consumed, typically that lead to increased calcium in the urine, leading to nephrocalcinosis and renal stones, is what you need to remember. So why less bicarbonate lead to increased calcium in the urine, less bicarbonate in the blood? There is a metabolic acidosis. When there is a metabolic acidosis, then what will happen? The bone will be, turnover will increase. That releases a lot of calcium and phosphate that enters into the urine, and that lead to development of nephrocalcinosis, and there is a development of the stones. Nephrocalcinosis in the case of the type 1, which is the distal renal tubular acidosis, is what you need to remember. Agreed, doctor? And always there is a competition between H plus and K plus to get secreted. If H plus is more in the blood, in exchange K plus is lost into urine. That's the reason there is a development of hypokalemia in case of distal renal tubular acidosis, is what I want to underscore to all of you. That's all is the story. Main 4 points you need to remember. It is the alpha intercalated cell which is problematic. It leads to hypokalemia, right? It leads to hypokalemia. Third, there is a nephrocalcinosis. What are the etiological factors leading to the distal renal tubular acidosis? Amphotericin B toxicity, analgesic nephropathy, and also SLE, and any congenital anomalies leading to obstruction of the renal tract, is what you need to understand. Now, let us talk about the proximal renal tubular acidosis. What is the problem in proximal renal tubular acidosis? Bicarbonate reabsorption is affected. Increased excretion of the bicarbonate in the urine, and that lead to the development of metabolic acidosis, right? But here the alpha intercalated cells in the distal renal tubule are still functioning. That's the reason they are still capable of secreting H plus and acidifying the urine. That is the reason there is a possibility for the urine pH to be less than 5.5, because alpha intercalated cells are working, no? So that is the reason urine can be acidified. Whereas in the case of the distal renal tubular acidosis, alpha intercalated cells are not working at all. H plus secretion impossible. Only thing that is possible is proximal renal tubule can excrete bicarbonate. That's the reason urine pH can still be more than 5.5. Alkalinity of the urine pH is possible in distal renal tubular acidosis. Acidification is not possible because alpha intercalated cells are not functioning, are not secreting. Whereas in proximal renal tubular acidosis, the urine pH can can still be acidified because though the proximal renal tubule is not working, still the distal renal tubule alpha intercalated cells are capable of secreting the H plus into the urine. That's the reason acidification is still possible, but acidification is impossible in distal renal tubular acidosis is what you need to remember. Whole secret is that only. Where is acidification possible? Where is acidification not possible? Acidification of the urine is not possible in distal renal tubular acidosis, and acidification is still possible in proximal renal tubular acidosis because though the proximal renal tubule is dysfunctional, still the distal renal tubules, alpha intercalated cells are still working. Still working is what you need to remember. Examiner will catch hold of your ear only in this point. Remaining things are all simple. Serum potassium is low, even in proximal renal tubular acidosis. Then what are the causes of proximal RTA? Fanconi syndrome. In Fanconi syndrome, you have proximal tubular dysfunction, amino aciduria, bicarbonatenuria, all these things are there, no? So Fanconi syndrome, proximal renal tubule. Multiple myeloma. Similarly, if you are using a carbonic anhydrase inhibitor, what will happen if carbonic anhydrase inhibitor is used, doctor? You know, in proximal renal tubule is what is happening? Proximal renal tubule secretes H plus that form carbonic acid, which is broken down into bicarb and H plus. And this bicarb enters into, and the CO2 enters into the cell. There it is converted into bicarb and reabsorbed. So this whole mechanism gets disturbed. If you are giving carbonic anhydrase inhibitor, that can lead to proximal renal tubular acidosis is what you should remember. Now, often these patients with proximal renal tubular acidosis, they have an increased risk of hypophosphatemic rickets. Their phosphate levels, what is happening in proximal renal tubule? They're losing the phosphate into urine, not only bicarbonate, phosphate into urine. Because of that, they develop hypophosphatemia and associated rickets is what you need to understand. So that is the story of proximal renal tubular acidosis. So mainly you should know what are the etiological factors. Can you acidify the urine or not? These are the 2 points you have to be 100% sure in the tomorrow's exam, doctor. Now, hyperkalemic tubular acidosis called renal tubular acidosis type 4. Type 1, type 2 have hypokalemia, but type 4 will have hyperkalemia along with acidosis. So what is the reason for it? So you all remember yesterday we discussed juxtaglomerular apparatus. What does it produce? Renin. Renin produce angiotensin. Angiotensin produce aldosterone. What aldosterone will do? It will come to the distal collecting duct, and here you have epithelial sodium channel. It will make sodium reabsorption. Same time it causes K plus H plus loss into urine. Suppose if this juxtaglomerular apparatus became a plastic, damaged, there is no renin, there is no aldosterone, there is no potassium H plus secretion. So potassium H plus are reabsorbed. They are not secreted, means they get collected in blood, and that lead to hyperkalemia and high H plus ion, which is acidosis, which leads to acidosis. That's the reason distal renal tubular acidosis is also called, renal tubular acidosis type 4 is also called hyperkalemic tubular acidosis. It's the only renal tubular acidosis which shows hyperkalemia. Proximal and distal will show hypokalemia. Type 4 renal tubular acidosis is also called hyporeninemic hypoaldosteronism, which is typically seen in the patients who have diabetic nephropathy very commonly. In the clinical practice, diabetic nephropathy individuals, their juxtaglomerular apparatus become destroyed by your nephropathy. Similarly, if you are giving ACE inhibitors, angiotensin receptor blockers, NSAIDs, heparin, cyclosporin, adrenal insufficiency, in all these scenarios, there is a development of hypoaldosteronism. Similarly, if you are giving potassium-sparing diuretics like spironolactone, which antagonize the aldosterone receptor. Spironolactone is a potassium-sparing diuretic. Why? When mineralocorticoid aldosterone need to act on the epithelial sodium channel, this spironolactone prevents it from acting on the receptor. Because of that, the sodium and the aldosterone cannot work. That lead to hypoaldosteronism. Anything that lead to hypoaldosteronism leads to type 4 RTA type of situation. Any nephropathy with obstruction or trimethoprim sulfamethoxazole, they also create a aldosterone receptor level resistance and lead to the development of hyperkalemic renal tubular acidosis is what you need to emphatically remember. Now, doctor, there is one important thing you need to remember about the type 4. In type 4, all this potassium unable to secrete become collected as water in the blood. That lead to hyperkalemia. Now, hyperkalemia also has an effect on proximal convoluted tubule. What is that? In the proximal convoluted tubule, ammonia is synthesized. And ammonia is what? NH3. For it to become NH4, what do you require? It combines with H plus. So obviously, when hyperkalemia is there, there's a competition between potassium and H plus always. If hyperkalemia is there, it won't let H plus marry the ammonia. So if it is not married to the ammonia, ammonium NH4 plus cannot form. If it can't form, then H plus excretion into the urine of NH4 doesn't happen. That is another way by which H plus excretion get impaired, leading to contributing to the acidosis. So this hyperkalemia also will contribute to the acidosis. Once more, this you try to summarize. Fundamental problem in renal tubular acidosis type 4 is hyporeninemic hypoaldosteronism. If the aldosterone is not there, H plus K plus secretion cannot occur in the collecting duct. That's the reason H plus K plus get accumulated. There is an acidosis, there is a hyperkalemia. Till there you understood. Additionally, also remember, in type 4 renal tubular acidosis, all that hyperkalemia competes, high potassium competes with H plus preventing H plus from binding with NH3 to form NH4 and get excreted in urine at the proximal tubular level. That also will impair the NH4 excretion and H plus excretion. So that is a problem in type 4 renal tubular acidosis. Are you clear? एक खाली 4-5 पॉइंट्स जरा दिल लगा के रिवीजन करो डॉक्टर. Good to see Tathagata Mondal, Dr. Joshi Sugandh, and many more. I want to find which day is called Happy Students Day, if there is a Happy Teachers Day, right? So, a teacher is a good teacher is a bad student who had a great struggle to understand the things. When we don't understand the things easily, like many other brilliant guys, then after passing through that struggle, we know how to make others learn better. Right? So, that is the whole secret to be a good teacher. Nothing you can understand in one go, doctor. Concepts like this, thoda ek step पीछे डाल के समझना. You understand? Put one step behind, look at it, once more try, did not understand, once more put another step behind, and then once more try. But without understanding, don't move forward in these concepts. Why hypophosphatemic cricket occur in type 1 or type 2? Proximal or distal? In proximal renal tubular acidosis, because proximal tubule is required for phosphate reabsorption. If it is not there, phosphaturia is there. Phosphaturia lead to hypophosphatemia. Hypophosphatemia will lead to prevention of the mineralization of the bone. That lead to the development of the hypophosphatemic crickets. In proximal renal tubular acidosis is what you need to understand. Good to see 15 online classmates. Now, doctor. So every day I will put 100 questions and a 30-second, 40-second voice file on the answer in the WhatsApp group. Morning 20 questions, afternoon 20 questions, like that. Without listening to that 30 seconds voice file in the WhatsApp, try to guess the answer. If needed, ask somebody, what is your answer? If needed, try to search for the answer before jumping to answer it directly. Then you listen the answer. So every day, WhatsApp also is a beautiful way, like YouTube, where we can work together to do as a group study, right? Every day 100 questions अगर हम WhatsApp में रोज पढ़ रहे तो next 100 days में 10,000 questions खत्म. That is all what is needed, right? So to be motivated morning to evening all the time, that is the whole secret of winning the entrance exam, doctor, right? So thank you, Ajay, Chandrakapure, and many more who are all online. Now, doctor, different casts in the urine, one of the favorite question. So typically cast means there is either hematuria or pyuria. It may be originating glomerular or it may be renal tubular. Agreed? So whenever there is any bladder cancer or whenever there are any kidney stones, you get frank hematuria, not cast. Understand? If cast is there, means the pathology is at the level of the glomerular or a tubular. If it is above the level of the glomerular, like kidney stones or bladder cancer, right? A bladder cancer is below the level of below the level, not glomerular tubular, below the level. There you find frank hematuria without any CAS. In acute cystitis in the bladder, there is a pyuria, WBCs in the urine, but no CAS. So if the RBC CAS are there, that indicates it is a glomerular level pathology. Another thing is, whenever the hematuria is because of a glomerular pathology, then that RBC is squeezing through the glomerulus and that becomes dysmorphic RBC. No more that biconcave disc-like RBC, but a dysmorphic RBCs are indicative that the hematuria is originating from glomerular level. Whereas bladder level, the hematuria, it won't form any CAS. Similarly, any kidney stones leading to erosion of the blood vessel and leading to hematuria, no CAS, only hematuria. CAS with hematuria is the feature of glomerular pathology or hypertensive emergency. There also, it is the RBC CAS. Then WBC CAS means there is a tubulo-interstitial inflammation or acute pyelonephritis or transplant rejection. Any of them can lead to WBC CAS. Then granular CAS, they have a muddy brown appearance, typically seen in acute tubular necrosis. Fatty CAS, they are oval fat bodies which are typically seen in nephrotic syndrome. Because nephrotic syndrome, there is a proteinuria, lipiduria, fat, protein, everything goes into urine. So, fatty CAS. There you see what is called Maltese cross sign whenever there are fatty CAS in nephrotic syndrome. Then waxy CAS, whenever end-stage renal disease is there or a chronic kidney disease is there, all the tubules are dilated. Inside that, the CAS will form in the same shape as the tubule. They are called waxy CAS. Hyaline CAS are a non-specific finding, normal finding whenever you are dehydrated or doing exercise or diuretic therapy. Diuretic therapy also can lead to hyaline CAS. And why they form, doctor? The renal tubules produce a protein called Thom's-Horsfall's protein. The Thom's-Horsfall mucoprotein secreted by the renal tubules normally to prevent UTIs, that typically form this normal CAS called hyaline CAS. They are not significant of any pathology is what you have to remember. Now let us look, doctor. What is this you are seeing? This is an example of a Thom's-Horsfall's protein associated hyaline cast is what you need to remember. Then, doctor, these are what are these called? These are called granular cast. And where do you see granular cast? Acute tubular necrosis. If you find this kind of granular cast, no, that is called angry urinary sediment. Oh my God, urine is angry, they say, nephrologists. What is poor man's renal biopsy, doctor? Poor man's renal biopsy. Poor man cannot afford a renal biopsy. Complete urine examination is called poor man's renal biopsy. A lot of times, urine sample report, no, you will throw it away. No, don't do that. There's a lot of secrets in the CUE. Complete urine examination is what you need to remember. So what you are seeing here are basically granular cause, which are the finding that you see in case of acute tubular necrosis is what you need to remember. So these are the WBC cells forming the cast in the urine of a acute interstitial nephritis. Acute interstitial nephritis. And what is this called as, doctor? Maltese cross sign, which is seen with fatty cars. In the patients who have nephrotic syndrome, when there is a lipiduria, that is all the story of CAS. Abhi aa gaya, doctor. NEET PG entrance is not for 200, 199. One question comes from glomerulonephritis. If you thoroughly understood glomerulonephritis, you understood nephrology. And if you have gone to exam with shakiness in glomerulonephritis, competition will kill your neck and go forward. Agreed? Yes. So what is the nomenclature of the glomerular disorders? First of all, focal, diffuse, proliferative, membranous, membranoproliferative, primary glomerular, secondary glomerular disease. Now the question comes, what are these, each of these definitions are? Focal glomerulonephritis. When less than 50% of the glomerular are involved, you call it as what? Focal. One of the best example is focal segmental glomerulosclerosis. That means only less than 50% got affected. Diffuse, more than 50% of the glomeruli are involved. That is what we call diffuse proliferative glomerulonephritis, DPGN. Proliferative means glomeruli are very hypercellular. So you have membranoproliferative glomerulonephritis. Membranous means the glomerular basement membrane got thickened. GBM got thickened. That's called membranous. So you have membranous nephropathy. Then what are primary glomerular diseases? That is basically the diseases in the kidney specifically impacting the glomeruli. Like minimal change disease is a disease primarily in the kidney leading to the glomerular pathology. Secondary, systemic disease leading to the pathology in the glomeruli. Any organ system involvement causing effect on the glomeruli, like diabetic nephropathy, SLE, all these are secondary glomerular diseases. Now let us look into this, doctor. What is this? Only less than 50% of the glomeruli are only affected, then you call. So this is the sclerosis. But all glomeruli don't show this. Only less than 50% glomeruli show this sclerosis, hence called focal segmental glomerulosclerosis is what you need to remember. So this is a normal glomerulus and this is the scar which is impairing the kidney function. And this kind of glomeruli are only less than 50% of the total number of glomeruli, hence called focal segmental glomerulosclerosis. So what is this? This is called diffuse proliferative glomerulonephritis. More than 50%, this all glomeruli are affected means diffuse proliferative glomerulonephritis. So this is the, remember doctor, this is the endothelial cell of that fenestrated capillary. This is the basement membrane. These are the epithelial cells. Two types of epithelial cells are there now. Visceral, parietal. Visceral will show food processes. Food processes are responsible for preventing albumin from leaking into the Bowman's capsule because food processes carry the anionic charges. Albumin also has anionic negative charge and both of them will repel each other and that prevents the albumin from getting lost into the urine. Then you have parietal part of the epithelium in the Bowman's capsule. All right. So there can be antibodies and antigens. They form an immune complex and deposit, and that lead to the GBM, the glomerular basement membrane, to become thickened. Then you call it as membranous glomerulopathy is what you have to remember. So very good to see Rajeshri, Kistiji, Pachauri, Dr. Swati, Dr. Linus, and many more. who are all online. So you can see here, doctor. This is the normal glomerular capillaries which are having thin wall. Normal glomerular capillaries which are showing thin wall. Whereas membranous glomerulopathy which is showing thick capillary wall in membranous glomerulopathy. Now, let us look at the glomerular diseases. Nephritic syndrome, nephrotic syndrome, nephritic plus nephrotic syndrome. The main difference is if there is hypertension, hematuria, smoky urine, that is what presentation of nephritic. If there is proteinuria, no hematuria, anasarca, edema, that is what? Nephrotic. So both types can occur in few of the conditions. So totally there are 9 glomerulonephritis, 4-5 points about each of them. Ho gaya 50 point. From that definitely one question will come. So but before that, nephritic syndrome mein kya hota hai? What happens in nephritic syndrome? There is an inflammation of the glomerulus that damages the glomerular basement membrane. Then RBCs will move into the Bowman's capsule because GBM is no more intact. That lead to dysmorphic RBCs and hematuria. And that RBCs form casts in the urine. There's a decreased GFR, oliguria, azotemia, increased renin release leading to hypertension. So hypertension, hematuria, oliguria, azotemia, these are all the features of the nephritic syndrome. There will also be proteinuria because GBM is destroyed, but it will be subnephrotic range proteinuria. Acha bhaiya, what is meant by nephrotic range proteinuria? If the amount of the protein lost is more than 3.5 grams per day, then you call it as nephrotic range proteinuria, is what you need to remember. Now, what are the conditions that lead to nephritic syndrome? Infections, post-streptococcal glomerulonephritis, PSGN we call. Then good posture syndrome, where anti-GBM antibodies, anti-glomerular basement membrane antibodies go and attack the glomerular basement membrane and lead to hematuria, which is called good posture. IgA nephropathy, which is also called Henoch-Conley's purpura, one end of spectrum, other is called IgA nephropathy, also called Berger's disease. Then Alport syndrome is a problem with the collagen. Type 4 collagen is there in the floor. Type 4 is in floor, which is there in the basement membrane, GBM. So Alport syndrome. Then membranoproliferative glomerulonephritis. These are the things that lead to nephritic presentation. So nephritis means, think of inflammation is what you need to understand. So what you are seeing here, doctor, these are all the dysmorphic RBCs. Which are the feature of? This is an isomorphic RBC, this is a dysmorphic RBC, which is a feature of glomerular pathology. Now comes nephrotic syndrome. So very good to see Vikas and many more. Very good. We reached 21 online classmates. So every day we study 3 hours revision, live face to face. Additionally, I'll post around 100 MCQs and 30-40 seconds ka answer. Every Sunday there is a grand test with discussion on Monday. Today I'll discuss in the night yesterday Sunday paper. So score app में चल रहे हैं क्या test? This week no problem. So score app download करके every Sunday mock test ले लो और Monday discussion attend करो. And 54,000 high yield facts I'll give as 1,500 pages notes. I'll also courier you if you are away from Hyderabad. If you are from Hyderabad, come to the class. We will enjoy. We'll have a cup of coffee and samosa. Today I did not bring anything there. So, khelte, next 4 months, I will study, you study, together we will study and we will make a topper. But I already, once upon a time, I was a topper. I finished my MD, General Medicine also. So, one of the students was asking, क्या है सर आप माइक्रोबायोलॉजी में स्ट्रेप्टोकॉक है, गायनेकोलॉजी में ओवेरियन कैंसर्स, ऑब्स्टेट्रिक्स में एक्लैम्सिया, सब कुछ एक ही हवा में पढ़ा रहे हो, आप कौन सा एमडी किया? हमने बोला भाई हम एमडी जनरल मेडिसिन किया, उससे ऊपर एमडी मेडिकल टीचिंग is an inborn error of metabolism for us. So अगर स्टूडेंट 19 सब्जेक्ट पढ़े तो पढ़ाने वाले अध्यापक भी 19 सब्जेक्ट्स पढ़ा सकते ना, है ना? Whereas if you have 19 different teachers, it is like having 19 fathers. Which father is drunkard, which father teaches well, other father will be very slow. कितने people को face करोगे आप? तो इसलिए आई एम योर रूममेट, क्लासमेट, बेंचमेट, टेबलमेट एंड स्टडी विथ यू डॉक्टर. So Dr. Abhishek acknowledges the way you teach, the knowledge you share, the care you do, the love you show makes you my favorite teacher. Good, doctor. Same also, Abhishek. The energy with which you study and the hopeful optimism with which you prepare. You know, always incurable optimism is infectious. Our positive vibe stimulates others. You know, what is the greatest service we can do in human life? To give hope to somebody. कोई patient का 2 centimeter breast cancer found. In internet, everywhere they study lobular carcinoma, bilateral mastectomy, otherwise radical mastectomy, that lead to lymphedema, that lead to lymphosarcoma. Poor person will be in a fear. But if you can give a hope, na, bhaiya 2 centimeter bole to it is still T1. There is a N0, your axillary nodes are not showing anything. PET scan is showing no metastasis, that's the reason it is M0. So don't worry, you will live longer than me. So you are my patient, I am your doctor, you are going to attend my funeral, not I am going to attend yours. Patient will cry in your arms. So to give hope is most important thing, doctor, always remember. So when you prepare for entrance now, there are 2 stages you are in. You finished only 10% of the subject and 90% not. One day you will finish 90% subjects of this 54,000 facts and only 10% left. But everybody before reaching that 90% completed, 10% left should start somewhere from 10% only completed, 90% remaining. वो कभी भूलना नहीं. When you are at 10% only completed, 90% not at, have the hope in your heart. You tell the world, एक दिन मेरा नंबर आएगा जब मैं भी 90% खत्म करूंगा. And after all, from reaching 10% to 90%, it only needs 4 months. of time. You study the 1500 pages, 54,000 points I give you. Study along with me, bas, you will reach that 90% point. It does not require any special secret mantra, how to read in last 30 days, 20 days, 10 days, no secret formula. Right? Ratta marna, batti marna, by heart karne ke liye, any brilliant guy has to do the same thing and pass through the same story is what you need to basically remember. So thank you all for joining, and please do come every day. So now, in nephrotic syndrome, there is an increased lipid production because lipid is supposed to be packed inside lipoprotein. For that you require apoprotein. That apoprotein is lost into urine. So that is the reason there is an increased lipoproteins, hypercholesterolemia. There is a frothy urine because of that appearance of the protein in the urine. Always, how do you identify proteinuria? Simple. When you passing urine, is it forming that effervescence? If the patient says, sir, when I'm passing urine, there's a lot of effervescence like that surf, then frothy urine, proteinuria. There'll be fatty casts in the urine. And in nephrotic syndrome, they are constantly losing antithrombin 3, which is anti-thrombotic. That's the reason it is a hypercoagulable condition. There's an increased risk of infection because they are losing the immunoglobulin G into the urine. And what is the main cause for the nephrotic syndrome? So you have two types now, Bowman's capsule, visceral, parietal. The visceral epithelium's podocytes, if they are damaged, then there is nobody to stop albumin to go into urine, because podocytes have negative charge. Albumin in the blood has negative charge, and this negative charge of the albumin repelled by the podocytes, and albumin is not permitted to enter into Bowman's capsule and urine. But the moment podocytes are damaged, no negative charges to prevent this negatively charged albumin from passing into the urine, and that lead to the development of proteinuria is what you need to remember. Then focal segmental glomerulosclerosis, minimal change disease, membranous nephropathy, amyloidosis, diabetic glomerulonephropathy. So when somebody says, please give me the list of causes for the nephrotic syndrome, what will you answer? Minimal change disease, membranous glomerulopathy, focal segmental glomerulosclerosis, diabetic glomerulopathy, and amyloidosis. 5 things should come to your mind, like that, for nephrotic syndrome. Then you have nephrotic syndrome, both. You have a nephrotic range of proteinuria along with nephritis like hematuria, hypertension, azotemia, everything. So diffuse proliferative and membranoproliferative glomerulonephritis are there, no doctor. They have a nephrotic syndrome like presentation is what you need to remember. Now, let us start with first, infection-associated glomerulonephritis. Earlier, we used to call PSGN, post-streptococcal glomerulonephritis. But now the modern term is infection-associated glomerulonephritis. So what's happening in streptococcal infection? There are antibodies binding with the streptococcal antigen. And these antigen-antibody immune complexes are coming and depositing in the glomerular basement. That lead to type 3 hypersensitivity reaction. Every time these infectious immune complexes are forming, complement is consumed. That's the reason there is a development of hypocomplementemia. So the most common cause for the infection-associated glomerulonephritis is group A streptococcus in children. And when do you see this? There is either a skin infection or a pharyngeal infection. Skin infection or pharyngeal streptococcal infection 2 to 3 weeks later. You know, there is a rheumatic fever, which is also streptococcal. But what is the difference? Rheumatic fever is caused only by the pharyngitic strains of the streptococcus, not by skin. Whereas glomerulonephritis can be caused by both pharyngitic and also skin, is what you need to remember. Huh? Complemented? What is complement? Good. Very good question. Thank you. You should ask such questions. If you don't ask, I will know you understood. Idli, sambar. इडली और सांबार खाने में एक टाइप ऑफ टेस्ट. Idli is antigen, sambar is antibody. They both go into your stomach. But if you put coconut chutney, then it becomes tasty. This chutney is called as complement. For this antibody to recognize that this antigen is an antigen, this antigen need to be made tasty, and that is the purpose of our complement system. So we have two things. One is called classical complement pathway and alternate complement pathway. Different complement components will be there, like C3A, C5A, C6, C7, etc. So every time immune complex forms, a complement is being consumed, and hence in the blood complement levels will become decreased. That's the reason you get hypocomplementemia. समझ में आ गया? Very good. And generally, post-streptococcal glomerulonephritis will not end in, what is the main fear? End-stage renal disease and chronic kidney disease. No, it does not lead to. It usually resolves spontaneously, is what you need to remember. Then another important point about PSGN you should never forget, doctor. If you get post-streptococcal glomerulonephritis, your complement levels decrease. But this decreased complement level normalizes by 3rd to 4th week. If it does not normalize and still hypocomplementemia is there, then that is not PSGN. This is another rule. Agreed? That hypocomplementemia once more should normalize. Clinically also patient should resolve. He should not end up in chronic kidney disease, is what you need to remember. So in adults, it is not streptococcus, it is the staphylococcus responsible. That's the reason, because both streptococcus, staphylococcus, both of them are responsible. Hence it is no more called PSGN. It is called infection-related glomerulonephritis. And it is a staphylococcal infection. And that infection site is variable. But usually it is not upper respiratory tract staphylococcus. But this post-streptococcal glomerulonephritis that you see in children will not progress to chronic kidney disease. But staphylococcus associated glomerulonephritis can progress to renal insufficiency, is what you need to remember. So what are the findings of infection-related glomerulonephritis? The glomeruli appear enlarged. They become hypercellular. And if you do immunofluorescence, there will be a lot of granular appearance. It's called starry sky appearance. And all that immune complex deposition will lead to lumpy, bumpy appearance. Because of that IgG, IgM, C3, complement component C3, deposition along the glomerular basement membrane and mesangium will lead to that lumpy, bumpy appearance, is what you need to remember. And on electron microscopy, what do you see, doctor? Subepithelial humps. So once more, you should know, subepithelial humps, where do you see? Subendothelial humps, where do you see? I mean, subendothelial deposits, where you see? You have to be very sure. What is this? Subepithelial immunofluorescent humps is what you see in case of infectious associated glomerulonephritis. Now let us look into this, doctor. So what are you seeing in this electron microscopy? Typically, all these deposits are subepithelial in nature. You have no visceral and parietal epithelium of the Bowman's capsule. It is subepithelial. And they are seen like a hump on the Bowman's capsule, like a hump. Camel has a hump, no? Like that, you see it on the Bowman's capsule. And what is this immunofluorescence appearance called as? Granular deposition, lumpy, bumpy deposition of infectious glomerulonephritis. Granular, bumpy pattern. Then what are you seeing here, doctor? Typically, there is a hypercellularity. Number of cells are increased. Hypercellularity is another important feature. Increased number of epithelial cells, endothelial cells, mesangial cells, neutrophils. They're all the features which you see in case of post-streptococcal glomerulonephritis is what you need to remember. Now this is another example. What are you seeing here, doctor? Hypercellular, post-infectious glomerular. This many number of cells you don't find in a normal glomerulus is what you need to understand. This is also called starry sky appearance. A pathologist पूरा आसमा में सितारे दिखा के हमको पैथोलॉजी पढ़ाते हैं. Starry sky appearance, you are able to see, right? Probably a romantic pathologist from Egypt or Rajasthan, Bikaner, might be lying down in a desert sand and watching that starry sky appearance is what you need to remember. One more example of increased cellularity in the glomeruli is what you are able to see. And because there is a proliferation of the parietal and visceral epithelial cells, the Bowman's capsule space become obliterated is what you need to understand. So what do you see in PSGN, doctor? Presence of hematuria, no CAS. There is also pedal edema. Pitting type of edema is what you are able to see. Then this is another example of typical starry sky appearance on immunofluorescence. And what are these, doctor? Hump. Sub-epithelial hump is seen below the podocytes in PSGN. That is all the story of PSGN. Next comes IgA nephropathy. As I told you, in the glomerulonephritis, 9 types of glomerulonephritis, 5 points, 50 points. 1 MCQ, shoot shot from this. What is IgA nephropathy? Patient will tell, doctor, 4 months ago when I had a sore throat, doctor. After 2-3 days, I was passing urine and blood came. I thought, let me wait once more before notification of NEETPG comes, before I come to you. So that resolved by itself, doctor. Then once more, I had similar sore throat. Once more, within 2 to 3 days, hematuria. Once more resolved. Now once more he came to you. That's the reason you remember. Benign, recurrent hematuria. Most common cause is IgA nephropathy. This is also called synpharyngitic hematuria. Why? Synpharyngitic hematuria. If you look at the post-streptococcal glomerulonephritis, there also first sore throat and then glomerulonephritis. But 2 to 3 weeks time is there between sore throat and glomerulonephritis. 2 to 3 weeks time in PSGN. But here, परसों आ गया sore throat, आज हो गया hematuria और कल फिर normal हो गया. Hence, this is called synpharyngitic hematuria is what you need to remember. So typically, any respiratory infection or GI tract infection, following that there is an episodic hematuria. And in both of these, respiratory is a external tract. GIT is also a tract. In all this, what is the secretory immunoglobulin IgA? So it is the IgA produced at the time of these infections that is causing the damage. That IgA is leading to vasculitis involving the kidney, leading to development of IgA nephropathy. That vasculitis can involve the skin, leading to the palpable purpurae, that is called Henoch-Conlin's purpura, HSP. Then if you do light microscopy, what do you see, doc? In the mesangial cells will be proliferating. If you do immunofluorescence, you can demonstrate that immunoglobulin A deposits in the mesangium. If you do electron microscopy, you can see in the mesangium the deposition. So mesangium is what you need to remember about IgA nephropathy. So this is what a mesangial deposition of the immunofluorescence in case of IgA nephropathy is what you need to remember. Now, basically in IgA nephropathy, this is the typical histology in IgA nephropathy. The mesangial hypercellularity is a very classical identifying feature on the microscopy. So what will you remember after tomorrow's entrance? Synpharyngitic hematuria, Henoch-Conlin purpura, IgA-related vasculitis. It can occur with respiratory or GIT infection के बाद you get IgA nephropathy. Then comes doctor RPGN. Nephrologists call it as RPGN, by rapidly progressive glomerulonephritis. The name itself is saying no, it is rapidly progressing. This is also called crescentic glomerulonephritis, not crest. It is not crescentric. I come from a Telugu medium background. I don't know what is crescent, what is crescentric. They both are not same. I still remember our chief saying, क्या बे सीट कैसे आ गया तुझे? Crescentric trick. There are no tricks in this. Crescentic. Come on, say tick. Oh, sir, crescentic. Then he asked, why do we get crescents in, what are crescents in crescentic glomerulonephritis? Typically, in the Bowman's capsule, you have visceral and parietal epithelium. That parietal epithelial cells proliferate and they form crescent-shaped lesion on the microscopy. So crescents are nothing but proliferative Parietal epithelial cells are the crescents. Once upon a time, there used to be wonderful teachers. They are top clinicians as nephrologists, but they used to hold your hand as a resident, take you to pathology lab, make you to see through the microscope, discuss the microscopic findings, once more go back to the patient. So learning clinical medicine is a joy. It's a ride. Whether you finish DM nephrology or super DM also, same concepts, fundamental concept yahi rehta hai. That's what you need to basically appreciate. So, doctor, rapidly progressive glomerulonephritis is the definition of, is a term used by clinicians, and crescentic glomerulonephritis is pathologist term. Whatever it is, there is a poor prognosis, rapidly deteriorating renal functions within days to weeks. In the light microscope, you find crescent moon-shaped, and this crescent consists of fibrin, the plasma proteins like complement C3b, glomerular parietal cells which are proliferative, monocytes, macrophages, a sub milke, they form crescents. Now, crescentic glomerulonephritis is not one disease entity. Many diseases can present with RPGN and crescentic glomerulonephritis. In some conditions, there can be good posture syndrome that can present like RPGN, like rapidly progressive glomerulonephritis. There, if you do immunofluorescence, you find linear immunofluorescence due to antibodies to the GBM, and the lung alveolar basement membrane can deposit. That's a possibility. When the good posture leads to RPGN. RPGN can be caused by many things. Whether it is Sushant, whether it is Taslim or Jafar, what's her name? Kulsum. Terminology is same. What is that junior resident? RPGN is also terminology. But that can be Sushant, that can be Shabana, that can be Jafar, that can be anybody. Right? So, one reason for the RPGN is good posture. There, if you do immunofluorescence, you find a linear immunofluorescence deposition. Sometimes there will not be there any immunofluorescence. That is called pauci-immune glomerulonephritis. Agreed? So, there are some vasculitis like your vaginous granulomatosis that also can lead to RPGN, where you have granulomatosis with polyangiitis along with ANCA, CANCA positivity. There can be eosinophilic granulomatosis with polyangiitis that can lead to the RPGN. Microscopic polyangiitis that can lead to RPGN. Like in microscopic polyangiitis, then myeloperoxidase, ANCA and P-ANCA will be positive. Then there can be granular immunofluorescence with RPGN, as in the case of the post-septal glomerulonephritis or diffuse proliferative glomerulonephritis is what you need to remember. So what are you seeing here, doctor? Typically, in rapidly progressive glomerulonephritis, if you do immunofluorescence pattern, you can find this kind of garland-like immunofluorescent deposition can occur with the formation of a crescent, moon crescent. So this is another example. So what are we seeing here? You are able to see, इसमें आप crescent को imagine करना पड़ता. ऐसा आके ऐसा हो गया, मून आ गया ना. So crescentic glomerulonephritis. In fact, this when parietal epithelial cells are too much proliferating, now what will they do to the Bowman's capsule? Lumen become obliterated, and filtration cannot occur. That lead to rapidly developing renal failure. Is what you need to understand. This is another example where you are able to see crescentic glomerulonephritis and proliferating epithelial cells are forming. So here you can imagine the presence of crescent with the proliferating cells obliterating the Bowman's capsule. That is all the story of rapidly progressive glomerulonephritis. Now let us quickly take each of these conditions. How do you treat, etc., etc. Good posture syndrome. How does the patient present, doctor? Hematuria, hemoptysis. Why hemoptysis? Because anti-basement membrane antibody is acting even on alveolar basement. Hematuria because it is acting on glomerular basement. Then type 2 hypersensitivity is good posture. So Sushant, what is type 2? What is type 3? Free floating antibody attacks a antigen fixed on a cell surface. This is type 2. Antibody free, antigen free, and both of them formed immunocomplex and came and deposited on a tissue. That is called type 3. So good posture is type 2. And how do you treat all these anti-GBM antibodies? You try to wash them out by doing plasmapheresis. And what do you find in GBM, anti-GBM disease, good posture? All these antibodies come and deposit in a linear fashion, ribbon-like fashion. Can you see that, doctor? Like a ribbon-like fashion, linear deposition of the anti-GBM antibody and leading to immunofluorescence. Then let's talk about diffuse proliferative glomerulonephritis. What is it because of? Very commonly, systemic lupus erythematosus lead to diffuse proliferative. Diffuse means more than 50% of the glomeruli are involved, and proliferative means all mesangial cells, everything is proliferating. Often this DPGN and MPGN, membranoproliferative, diffuse proliferative, present with nephrotic syndrome and nephritic syndrome concurrently together. And what do you see in SLE? Wire looping of capillaries, wire loop lesions. Immunofluorescence is granular, but in diffuse, in lupus nephritis, it is all subendothelial, sometimes subepithelial or intramembranous, but predominantly subendothelial is lupus nephritis. Now let us look into the lupus. So what do you see here, doctor, in the case of the lupus? The glomerular capillaries are all thickened. And this thickening is typically showing the presence of wire loop like appearance, which is typical of lupus nephritis. What are these called? Wire loop appearance is what you need to remember in SLE, lupus nephritis. So fundamentally, you should have some mental picture about the glomerulus, doctor. First, let us talk about it. So, you should know very well that you have this, what is this basically? Capillary endothelium, which is a fenestrated type of capillary. Then you have these things which are called as podocytes, which are the part of the visceral epithelium. Inside the capillary lumen, you have the RBC, is what you are able to see, right? Now, we'll once more come back to that. What is meant by Alport syndrome? In this, typically there's a problem with collagen. It is an X-linked dominant condition. Very few conditions are X-linked dominant. In this, the tubular cells become foamy because of the accumulation of the fats. So, Alport is a hereditary nephritis where deafness, eye problems, glomeruli show irregular thickening, thinning, and splitting of the basement membrane is what you typically see in case of Alport syndrome. Then what is this finally called as, doctor? Typically, there is a chronic glomerulonephritis with the thinning of the renal cortex, with atrophic kidneys. This is called ESRD, end-stage renal disease. When the patient reaches this stage, he becomes dialysis dependent, and you need to give kidney replacement is most important part of the treatment. Now let us talk about MPGN, membranoproliferative glomerulonephritis. So what are the two conditions that present both with nephrotic and nephritic syndrome like presentation, doctor? DPGN and MPGN, both nephrotic, nephritic. So this also presents with nephritic along with nephrotic. And what lead to MPGN? Remember, hepatitis B, hepatitis C lead to the development of MPGN. Point number 2. It can even be idiopathic. And where are the deposits? Subendothelial deposits. Lupus nephritis? Lupus nephritis. Predominantly, you remember where were the things in lupus nephritis? Just before we discuss lupus nephritis, 1 minute. Subendothelial is lupus nephritis, predominantly subendothelial. And also what you are seeing here, MPGN. MPGN also predominantly subendothelial and granular. And what is depositing? C3 nephritic factor. So what is C3 nephritic factor? Immunoglobulin G autoantibody, which stabilizes the C3 convertase enzyme. There's an immunoglobulin G autoantibody that will stabilize the C3 convertase. C3 convertase, what it will do? It will cause activation of complement. And that complement activation will lead to the consumption of the complement, leading to decreased C3 level. That is what you see in case of membranoproliferative glomerulonephritis. Sometimes in membranoproliferative glomerulonephritis, instead of being subendothelial, deposition can even occur inside the GBM. Then that is called intramembranous deposits. When such deposits occur, it is called dense deposit disease, is what you need to remember. Now, MPGN has two types, MPGN type 1, MPGN type 2. In both these types, the mesangium will grow inside. You have GBM, you have mesangium, and lead to splitting of the glomerular basement membrane. It looks like a tram track if you do the hematoxylin eosin staining. Tram track means track, no? Kolkata met trains inside the city, tram track. because the splitting of the GBM, because of the mesangial ingrowth is what you need to remember. So this is a classical MPGN which you are able to see, doctor. And overall, what do you find? Increased mesangial cellularity is what you are able to see. Hence, it is proliferative. Mesangio-proliferative glomerulonephritis, MPGN. I mean, membranoproliferative glomerulonephritis. Now, what do you see here? The glomerular basement membrane, doctor, if you appreciate here, is being split. These are all tram tracks. Can you appreciate? What is this? You are finding a tram track. So tram track appearance because of the splitting of the GBM is the hallmark of membranoproliferative glomerulonephritis. Then what are you seeing here? Typically, the mesangial cells which are proliferating and subendothelial membrane, deposits. Subendothelial deposits is the characteristic feature of MPGN is what you need to see. Once more, this is another example where are the deposits? Subendothelial deposits is what you are able to see. But in this case, they deposited directly in this is GBM. So directly they deposited in the GBM. What is this called? Dense deposit disease. Tram track is, GBM, typically there is a splitting and depositing occurring directly within the GBM. So then that is called as dense deposit disease is what you need to remember. So here you can see inside the GBM, there are deposits which you are able to see inside the GBM. So this is called dense deposit disease. Earlier days, they used to call MPGN type 2 as dense deposit disease, but nowadays it is only directly they call it as dense deposits disease is what you need to understand. Now, why I'm showing this is there are only 4 or 5 points there which you need to ingrain into your mind. Normally it is subendothelial deposits, but if it is a MPGN type 2, then it is a intramembranous deposits. That is called as dense deposit disease. That point only. And tram track appearance because of the splitting of the glomerular basement membrane. That only should get into your mind. This is another example where you can see the presence of the membranoproliferative glomerulonephritis is what you need to remember. So that is all the story of MPGN, doctor. So already we finished 1.5 hours. So you want to have a break? We'll take a 5-minute break. So totally how many points are there in nephrology? Quickly check and tell me. Hmm? 100 and? Oh, there are only 131 points. Eh? Very good. So another 60 points to go, I believe. And if you have energy, we will run. So mainly, sometimes we get slowed down because you need to understand where is the GBM, where is the intramembranous, where is subendothelial, where is subepithelial, what is meant by immune complex, what is meant by posse-immune, where is the complement is decreased, where it is not decreased. That only is the story in entire glomerulonephritis. Remaining part is all easy. Renal tubular acidosis also require little slow going. That's the reason I'm going slow. Am I going slow too? No, no. Okay. So please go into the kitchen, pick up a nice cup of tea, and we will rejoin. So Kirti is asking, sir, I have issue with the app access. Please call Kirti 9000868 356. Please do call uh, or directly WhatsApp me your number. I'll take it up and then resolve it for you. 9000868 356. So, welcome back to the game, doctor. Minimal change disease. Minimal change disease is also called lipoid nephrosis. And the most common cause of the nephrotic syndrome in the children is minimal change disease. Often it is idiopathic, karma, and recent infection, immunization, anything can be triggering factors. So you can remember four I's about minimal change disease. I, it can be idiopathic, I is infection, I is immunization or immune stimulus. Rarely it can be secondary to lymphoma, where lymphoma cause cytokines to get released and that lead to the damage to the food processes of the podocytes on the visceral endothelium, epithelium of the Bowman's capsule. If it is a primary disease, it has an excellent response. If you give steroid, gone. But if it is secondary to any underlying lymphoma or any underlying reason, then not a good response. On light microscopy, nothing is seen. Everything looks normal glomeruli. Of course, sometimes you may see a lipid in the proximal tubular cells, because nephrotic syndrome lead to proteinuria, lipiduria also. Immunofluorescence is negative. No deposits, no granular, no lumpy, bumpy, no subendothelial, no subepithelial, nothing. And electron microscopy only abnormality is seen, and that is the effacement of the food processes of the podocyte. Typically, they present with massive hematuria, more than 3.5 grams per day is what you need to remember. So, this is what you need to have a mental picture, doctor. This is a normal gram stained, normal glomerulus pass stained. It stained the glomerular basement membrane and also the capillary loops, right? All these capillary loops are also stained. And you can see the endothelial cells inside these loops, capillary loops. And the Bowman's capsule with parietal epithelial cells is what you are able to see. So this is a normal capillary. What do you have here? Fenestrated endothelium. Then this is the glomerular basement membrane. This whole thing is what? This one is glomerular basement membrane. And this is the visceral epithelial cell, and the food processes of the visceral epithelial cell is what you are able to see. But this food processes got effaced, which is the underlying problem in minimal change disease, is what you need to remember. So what do you see? This is typically a normal glomerulus with normal endothelial and mesangial cells and surrounding tubules which are also normal. Tubules which are also normal. So you have a basement membrane, then it is the fenestrated endothelium of the blood vessel. This is the RBC, and this is the podocyte of the visceral endothelium, and you are able to see the food processes, podocyte of visceral epithelium of the Bowman's capsule. And this is all the mesangium, and these are the mesangial cells, and this is all called mesangial matrix. So these are the endothelial cells, and this is the fenestrated endothelium. This is what should sit in your mind. Then everything else is a game. So what are you seeing here, doctor? You are seeing the minimal change disease where the food processes are all effaced. Effacement of the food process is there, is what you are able to see. And fusion. This is another example where you are able to see diffuse podocyte damage with the loss of the slit diaphragm. And normally podocytes appear like spikes. They're all fused with each other, is what you are able to see here. That is the minimal change disease. Understand? Now, focal segmental glomerulosclerosis. This also presents like nephrotic syndrome. You remember, no, 5 pathologies that present like nephrotic syndrome. Diabetic nephropathy, amyloidosis, focal segment glomerulosclerosis, minimal change disease, and membranous glomerulopathy. These 5 will present with nephrotic syndrome. 2 pathologies present both nephritic picture. What are they? Diffuse proliferative glomerulonephritis and membranoproliferative glomerulonephritis. Agreed, doctor? So all these concepts, no doctor, ऊपर से नहीं, उसके अंदर जाके दिल के अंदर रख देना, ताकि tomorrow when you go to the exam, no, examiner should know who came to the exam. Why से लिखना exam को. Twist turns is, even if examiner is trying to present, you know where is the twist in that. You know what is Winter's formula, what is meant by compensated metabolic acidosis, what is not compensated. Everything you should be ready. Okay. So focal segmental glomerulosclerosis. It can be idiopathic or it can be secondary. The 5 causes for secondary, फटाफट बोलना है. Focal segmental glomerulosclerosis is seen with HIV, sickle cell, heroin drug abuse, obesity, interferon treatment, and congenital malformations. Primary disease always responds good to steroids. And FSGS can proceed to chronic kidney disease. And what you see on light microscopy, you can see all that hyalinosis, segmental sclerosis, all that you can appreciate on the light microscopy. Immunofluorescence is negative, but there can be focal deposits of IgM, C3 and C1. Electron microscopy show effacement of food process similar to minimal change disease. That's the reason it presents with nephrotic syndrome-like presentation, is what you need to remember. So you can see all that hyalinization, scar formation in the glomerulus in FSGS is what you need to remember. Then once more, this is the normal glomerular part, whereas this is all what? Hyalinization, focal segmental glomerulosclerosis. It's called trichrome stain for FSGS. Once more, here you can see hypercellular glomerulus, and the capillary loops are poorly defined. There is also proliferative glomerulonephritis. This is DPGN, diffuse proliferative glomerulonephritis. And once more, this is another, already we have seen, post-infectious diffuse proliferative glomerulonephritis. This is also lumpy, bumpy, granular deposits of DPGN. So that's a point. Then comes membranous nephropathy. Generally, the rule is like this, doctor. Whenever the patient is having proteinuria, nephrotic syndrome can be because of minimal changes, membranous nephropathy, FSGS, amyloidosis, or diabetes. Normally, proteinuria will be only around 3.5 to more than 3.5 means 4, like that. But if there is a massive proteinuria, massive, that is 11 grams, 12 grams, then you should always suspect the possibility of FSGS. FSGS also lead to nephrotic syndrome, but FSGS proteinuria will be a massive proteinuria, is what you should remember. Now, coming to membranous glomerulonephritis. Membranous glomerulonephritis can be primary, where antibodies to the phospholipase A2 receptor are created, will lead to the membranous nephropathy with proteinuria. But it can be secondary to drugs, secondary to infections, NSAIDs, penicillamine, gold can lead to membranous glomerulonephropathy with the nephrotic syndrome. Hepatitis B virus, hepatitis C virus, syphilis, membranous nephropathy. SLE, very important. Solid tumors like lymphoma. Always a elderly patient of about 65 or 70 present with membranous glomerulopathy with nephrotic syndrome. Commonly, nephrotic syndrome means, what will you think? Oh, okay. How many years you have diabetes, sir? Sir, I am having for the past 20 years. Oh, because diabetes is there. That's the reason he got membranous nephropathy or diabetic nephropathy. So he got nephrotic syndrome, you will think. But if the patient is above 60 years, if at all he is non-diabetic, but presenting with nephrotic syndrome, immediately you need to evaluate whether there is any lymphoreticular malignancy or if there is any underlying solid tumor. Why this man is getting the nephrotic syndrome, you need to evaluate, and quite often you will discover membranous nephropathy with an underlying lymphoma or a solid tumor is what you need to remember. So membranous nephropathy also increases the risk of thromboembolism. So it can lead to DVT, renal vein thrombosis, and it has a poor response to steroids. Children, minimal change disease has got a good response, but here poor response. It can progress to chronic kidney disease. And what do you see in light microscopy? Diffuse capillary and glomerular basement membrane thickening. That is what you see on light microscopy. Then if you do immunofluorescence, you find granular deposits, spike and dome appearance of subepithelial deposits. What do you see, doctor? Spike and dome appearance. And what is this? Subepithelial. Once more, now summarize. Where do you find subendothelial deposits? Very good. Coffee? Huh? Huh? Oh. Thank you, bud. Huh? So, spike and dome, appearance of subepithelial deposits. So, once more summarize, doctor. Lupus nephritis, subendothelial, wire loop lesions. Then where else you find subendothelial? One more location, MPGN, subendothelial or subepithelial. Subendothelial. In dense deposit disease called MPGN type 2, it is intramembranous. Then membranous nephropathy, what do you find? Subepithelial is what you are able to see. And it presents with nephrotic syndrome is what you should remember. So, doctor, this is what you can see. The glomerular basement membrane is grossly thickened in membranous nephropathy, is what you need to remember. Okay. Now, this another example where you are able to see the spike spike and dome pattern of thickening of the glomerular basement membrane, spike and dome pattern in case of membranous glomerulopathy. This is the granular appearance that can also be seen in the case, GBM, thickened GBM is what you are able to see in membranous nephropathy. And this is another example where you are able to find the GBM, which is thickened in glomerular basement membrane. And what is this, doctor? Crescents. This already we discussed. Crescentic glomerulonephritis in leading to RPGN. All right. Now comes amyloidosis. Amyloidosis also presents with nephrotic syndrome. Of all the organs, kidneys are most commonly involved organ in amyloidosis, in systemic amyloidosis. So there are different types of amyloid. Which type of amyloid is known to lead to renal involvement? AL amyloid, AA amyloid, or any prolonged dialysis associated amyloidosis, anything can lead to kidney involvement. Congo red stain is used that lead to apple green birefringence under the polarized light because of the amyloid deposit in the mesangium, which presents with nephrotic syndrome. So all these, can you see these amorphous deposits, doctor? These are all what? Amyloid. Here to pura painting ho gaya. Amyloid. This another amyloid deposit on Congo red staining is what you are able to classically see. This one more example of the amyloid going and depositing and leading to the development of amyloidosis. Amorphous deposits. If you look at the gross appearance of the kidney, typically that amyloid deposition typically also will appear in the gross appearance of the kidney. If you check the kidney also. Then comes diabetic glomerulonephropathy. The most common cause of the end-stage renal disease, diabetic glomerulonephropathy. Why diabetes lead to kidney involvement? Diabetes may, you are having hyperglycemia. Hyperglycemia lead to a non-enzymatic glycation of the tissue proteins. Tissues have proteins. That proteins, without any enzyme, the glucose which is excessive will come and glycate those proteins in the tissues. So this non-enzymatic glycation of the tissue proteins, they are called amidary proteins. Amidary proteins. In turn, they will cause mesangial expansion. There is a GBM thickening, increased permeability, and there is a hyperfiltration. Because of that increased permeability, glomerular filtration will be more. Increased GFR, and that lead to glomerular hypertrophy, ultimately glomerular scarring, leading to glomerulosclerosis. This much will happen in the kidney. Just a simple sugar control. Sugar lead to glycation, glycation lead to amidary, amidary lead to mesangial proliferation, mesangial proliferation lead to all the dirty things. There is a glomerular hypertrophy, glomerular scarring, increased permeability, GBM thickening. All these things will occur. And ultimately, there will be eosinophilic nodular glomerulosclerosis, which is called Kimmel-Steen Wilson's lesions are characteristic of diabetic nephropathy. So what do you see here, doctor? Nodular. Can you see this nodular glomerulosclerosis, which is called Kimmelstein-Wilson's disease, is what you need to remember. This is another example of nodular lesions which typically develop in Kimmelstein-Wilson's disease. This is one more example of diffuse glomerulosclerosis. Ultimately, kidney become all sclerosed into a shrunken kidney in the diabetic nephropathy, which lead to end-stage renal disease. That is all the story of glomerulonephritis, doctor. Very good. एनर्जी है, बहुत पढ़ लिया. So totally how many points? 130, 131 ना 100 मार्क के जाएंगे. Are you ready? 100 fast. रिमेनिंग इज ऑल खेलते खेलते पढ़ सकते, उतना टेंशन नहीं है. Now, let me ask our online classmates. We have 17 classmates. So past 2 hours you are all laboring. You feel still will hit 100. Rohit Sharma's 110. And then go. Everything is willpower, doctor. When you feel like giving up, you don't give up, and then continues resuscitating your patient will be alive. But you give up, God, right? So let's please punch. Shall we continue? Shall we stop? Let me know. Punch into the chat window. So, doctor, kidney stones. Every medical college batch, 4 or 5 students will be there who will have, at least 2 students will be there who will have renal stones. Right? So, renal stones is very common problem. Bread and butter of a urologist in this tropical country called India, where we are dehydrated in summer. So, renal stones can lead to kidney injury, hydronephrosis, pyelonephritis, anything can happen. Unilateral flank tenderness, colicky pain, radiating from loin to groin with the hematuria. How can you prevent it? Take fluids. 2 types of kidney stones are radiolucent. Cystine stones, uric acid stones are radiolucent. You can't see them. I can't see you. You can remember, I can't see you. C for cystine, U for urate are radiolucent is what you need to remember. So online students should punch whether you have energy to hit 100 points by the end of the day. Please do hit into the chat window. So how many types of kidney stones? Calcium stones, right? Then you have ammonium magnesium phosphate stone, which is called struvite stone, uric acid stone, cystine stone. 1-2 comments about each of them. Calcium stones, whenever the amount of citrate inside the urine is low, hypocitraturia is there, that lead to precipitation of the calcium oxalate stones. So in the calcium stones you have calcium oxalate, calcium phosphate, 2 types of stones. For calcium oxalate stones, the main reason is low citrate in the urine is responsible. Calcium oxalate are radio opaque stones. They are like an envelope or a dumbbells, right? Dumbbell, dumbbell shaped. Then we have calcium phosphate stone. Any increased pH of the urine, like an alkaline urine, will precipitate a calcium phosphate stone. And they are also radio opaque. Then ammonium magnesium phosphate stone is also called struvite stone. And typically it has a coffin lid of the coffin. How will be the lid of a coffin? Like this. This is the shape. They are like a coffin lid shaped crystals. Then uric acid stone. Uric acid stone precipitates if the acidic pH is there for the urine. They are radiolucent on X-ray but still visible on CT. Which ones? Urate stones. They are rhomboid in shape. Rhomboid in shape. And they can present like rosettes. Then cystine stones. They precipitate whenever there is an acidotic pH, similar to uric acid stones. X-ray, they are faintly radio opaque, and CT, they are moderately radio opaque. They are hexagonal in shape. So you can remember cystine means cystine has 6 sides, hexagonal. Rhomboid is urate. Now we will go a little deep into each of them. Of all these stones, calcium stones are maximum number. Between calcium oxalate, calcium phosphate, which is more common, calcium oxalate is more common. And why calcium stones are precipitated? What are the etiological factors? Remember, ethylene glycol ingestion, vitamin C overuse, hypocitraturia, low citrate. Then, because citrate prevents the precipitation of calcium oxalate stones. Then any malabsorption of the oxalate lead to typically lead to malabsorption disorders, lead to Crohn's like disease, lead to calcium oxalate stones. So you should not forget these etiological factors. Sure shot examiner will ask you. And how do you treat, doctor? Thiazides, give citrate, give low sodium diet. Thiazide, citrate, low sodium diet. These are the ones which you typically administer whenever calcium stones are there. Why thiazide? Yesterday we discussed, no? Lipodiuretics lose calcium into urine. But thiazide diuretics retain calcium. So lead to hypocalciuria. That's the reason you use that hypocalciuric function of the thiazides to treat the calcium stones is what you need to remember. Ammonium magnesium phosphate. It is also called struvite stone. It is due to the infection with urease producing bugs. Proteus mirabilis, Staphylococcus, Saprophyticus, Klebsiella. All these organisms, they produce urease. And they hydrolyze the urea into ammonia. That lead to alkalinization of the urine, in which these ammonium magnesium phosphate stones are precipitated. So you know stag, no? Ginkgopila. Stag horn calculi. And how do you treat? Eradicate Proteus. Eradicate the Proteus infection. So proteus mirabilis, Staphylococcus saprophyticus, Klebsiella, the three infections leading to UTI, where they produce urease and lead to alkaline urine, precipitate staghorn caliculi. And staghorn are very big. They will make your kidney gone. So surgically you need to remove the stone. This is a big staghorn caliculi. This is another example of a staghorn. Nothing is left. The renal cortex became so thin. Everything occupied by this horn. This is another example of a big staghorn calicus and staghorn calculus and hydronephrosis. That is all the story. Then comes uric acid stone. 5% stones are all uric acid. Any decreased urine volume, hot climate, acidic pH lead to urate stones. Often associated with hyperuricemia. Anything that increases the cell turnover like leukemia, what will happen? Whenever leukemia is there, cell turnover increase, all the cell nucleus will release the purines. Purines break down to form uric acid and that lead to hyperuricemia leading to uric acid stone. So how do you treat it? Alkalinize the urine and give allopurinol like drug which decreases the urate level. Coming to cystine stones. So cystinuria is a hereditary autosomal recessive condition where in the proximal renal tubular, proximal convoluted tubule, the cystine reabsorbing transporter lost its function. So it is not only cystine, along with the cystine, cola. C for cystine, O for ornithine, L for lysine, A for arginine, cola. Ornithine, lysine, arginine, cystine, all the four are lost in cola, which is typically seen in cystinuria. And cystine is poorly soluble, forming the stone. It is usually begins in childhood. It can also form staghorn caliculi. And how do you identify that? We use sodium cyanide nitroprusside test to detect the cystine in the urine. So how do you treat? Give low sodium diet, alkalinize the urine and give chelating agent like tiopronin penicillamine. Tiopronin penicillamine are the chelating agents to treat the cystine stones. How are the cystine stones shaped, doctor? Six-sided or sixtine stones, hexagonal crystals. So these are the coffin lid appearance of the which is coffin lid? Struvite. Struvite is all coffin lid. Okay. This is cystine. This is rhomboid. Uric acid is rhomboid. What is this? Envelope shaped. ये मेरा प्रेम पत्र पढ़कर तू समझ लेना कि oxalate crystals हैं. So that is the oxalate. So what do you see here, doctor? This is a large renal calculus obstructing the lower pole of the kidney, leading to the hydronephrosis is what you are able to see. This is another example of chronic urate nephropathy where the deposits, tophaceous deposits of the urate crystals are able to see in a patient of lymphoma who is having tumor lysis with the resulting release of uric acid leading to the urate nephropathy. Now comes hydronephrosis. Ibiabuchi Patrick says, sir, continue. I'm enjoying the class. Munish Shivakumar is saying, 100 मार्क के जाएंगे, उससे कम नहीं। थैंक यू डॉक्टर रविंदर सिंह जोशी, स्वाति एंड एवरीवन, आपके फरमाइश के से हम कंटिन्यू करेंगे। ये चीज ऐसा है ना डॉक्टर, every line is high yield in this. Only you need to read these things. What is needed, I am giving you. Forget about Bailey and Love, forget about Harrison, forget about microbiology Anantanarayanan. खाली एक चीज में मोक्ष है। 1500 pages notes I give you, and I don't put all illustrations and make it big book. All illustrations are there in Google. डाउट आए तो गूगल मारो, उसमें हेक्सागोनल क्रिस्टल दिखता है, उसमें कॉफिन लिड क्रिस्टल्स दिखेगा, मेम्ब्रेनस ग्लोमेरुलोनेफ्राइटिस दिखेगा। वो पूरा बुक्कों में डाल के बुक को मोटा मोटा करने में क्या मजा है। That's the reason I packed all the high yield facts compactly into this 1500 pages. Somehow you master. Agreed? And don't listen to videos. Let me tell you once more, that is the most important trick, doctor, I'm telling you. अगर आप क्लास सुने तो वीडियो का जरूरत नहीं है, बकवास है। क्योंकि जहां भी रीजनिंग का जरूरत पड़ेगा, अभी हम डिस्कस कर रहे हैं, समझ में आ रहे हैं आपको, दूसरे मर्तबे देखने में क्या मजा है। बट इफ यू मिस्ड द क्लास, देन the points in the notes you are able to understand, go to the video. Otherwise, videos will slow down your preparation. मैं बोल रहा हूं, it's a waste of life, right? What is ultimate is the 1500 pages, 54,000 points I am couriering to you. Every day, make it a point that you do revision of 30 to 40 pages. Each page में 10 paragraphs and 30 points are there. 30 pages you revise means 1000 high yield facts you are revising. बीच में कोई point doubt आ गया तो go to the score app. In the score app there is a video library. In that the same subjects are there. Just click on type. This is the, in the notes it is the 20th point. I want to know the logic. 20 number maro search में that particular video will come. Just revise that video. Okay? So don't otherwise listen videos. It's a waste of time. Let me tell you. And don't read anything which is not tested in exam. Don't read anything that you cannot revise. These are the principles you need to carry. And don't imagine 1 year full time is required for me to become topper. Nothing. I just need 600 hours of your precious time to sit with Dr. Murli. I'll prepare notes every day. What is definitely going to come in exam? And then we will have a discussion. Be part of it. Take the grand test. Take the grand test, attend the discussion on Monday. Sunday, grand test on score. Whatever be your level of preparation. By November 30, we will finish everything. December onwards, every day we will have one grand test discussion, right? But if your 54,000 points are strong, then you will enjoy doing grand tests. But from now only, make it a habit, okay? So if you stick to this, doctor, आपका seat, मेरा जिम्मेदारी. Next 4 months, be with me. Similarly, every day I'll post 100 points with the audio file of the solution to that in the WhatsApp group. The WhatsApp will be buzzing, bing, 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 bing. WhatsApp is very personal thing. It is more like a phone. But we are in the middle of war. We are in the middle of hot war. We have to win. Dharma yuddhe kurukshetre. Right? We have to win. That's the reason I don't use Telegram or I won't use my own score app. If it is WhatsApp, every moment I am disturbing you और आप भी आंसर कर रहे, पूरा दिन आप charged है preparation में. Once you get seat, run away from the WhatsApp group. And only if you have that strong commitment to become the topper, be the part of the WhatsApp group, study group. All right. We have almost all 10,000 students. Every day new students are growing. So nowadays, how to inspire, teach students through WhatsApp. I'm going to present a paper in European Medical Education Conference in Scotland, right? And the best example, I'm going to show your data. See, this is how you don't need an app, you don't need anything, just WhatsApp is enough, right? So, good doctor. So, hydronephrosis, dilatation of the renal pelvis and calyces. And why hydronephrosis occur? Typically from the kidney, the calyces, minor major calyces drain into the ureter, that goes and mix with bladder. Any obstruction in bladder, any obstruction in urethra, any obstruction in ureter, there is a back pressure happening on the kidney that lead to hydronephrosis. Kidney is a retroperitoneal structure. Ureters are retroperitoneal in nature. So any retroperitoneal fibrosis lead to compression and obstruction of the urinary tract leading to hydronephrosis. Any vesico-ureteric reflux from the bladder, if the urine is refluxing back, that can lead to. In all these scenarios, creatinine is elevated, kidney is atrophied, is what you are able to see. So, doctor, this is a classical example where your pelvic calyceal system is significantly dilated. Here even ureter is significantly dilated, is what you are able to see in hydronephrosis because of a long-standing obstruction. Once more, we come to a very interesting topic called urinary incontinence. You remember the physiology of peeing. Physiology of peeing. What makes us to urinate and control our urination, micturition. So the micturition control center is in pons. It is the parasympathetic innervation which controls the peeing. So you have a bladder, doctor. It has got a detusar muscle. Then you have a urethra, proximal and distal urethral sphincter, and this urethral sphincter is controlled by both sympathetic and parasympathetic. Sympathetic relaxes this, sympathetic constricts this sphincter and lead to continence. Parasympathetic relaxes the sphincter and let the urine pee out. P for parasympathetic, let you to pee. And parasympathetic also supplies the detusar and cause the detusar contraction leading to peeing. Now, how many types of incontinence? That means patient is peeing without his control is incontinence. Urge incontinence, stress incontinence, overflow incontinence are the three types of incontinence. Urge incontinence. Suppose you have any bladder infection like cystitis. The bladder detusar became irritable. It is strongly contracting beyond the capability of the sphincter to stop it. And that is leading to stress incontinence. The person, little urine he passed only, that cystitis bladder is making him to go into spasm and create that urge to urinate. That's called stress. And that's called urge incontinence. The other is stress incontinence. It is this uretrovesical angle is being maintained by a lot of muscles surrounding it. So suppose if a woman delivered a lot of babies, etc., this muscle became weakened and that uretrovesical angle is lost, and that lead to stress incontinence. Stress incontinence. The third is overflow incontinence. You had any spinal cord injury that destroyed your parasympathetic innervation. then the bladder became atonic. And this atonic bladder, what happens? Urine keep on collecting, and it doesn't know how to contract. A point will come, it became so contracted that it won't blast. That will cause seepage of urine down, overflow. Pot के अंदर पानी लगा रहे हो, you are pouring water it full, then it starts overflowing as new urine comes. That's called overflow incontinence. Now, 4-5 points about each of them. Stress incontinence. Any problem with the intrinsic sphincter deficiency or urethral hypermobility, because of the uretrovesical angle is affected, lead to stress incontinence. Whenever the intra-abdominal pressure increase, so a lady who had 5 to 6 deliveries, so she is a typical patient. So she went to a party, there was a joke, she was laughing, and that led to seepage of urine. Any lifting, sneezing, anything. So in this, there is a positive bladder stress test. That means you ask the patient to cough or do Valsalva maneuver. That is against a closed glottis, you do expiration, you ask. Mukkadam, that's what we call in Telugu, right? So you do that, if the patient coughs or do Valsalva maneuver, that lead to direct leakage of the urine from the urethra, which is called positive bladder stress test. So any obesity, pregnancy, vaginal delivery, prostate surgery also in men can lead to stress incontinence. And how do you treat? Basically, pelvic floor muscle exercises. So every obstetrician should be also yoga teacher. After the delivery, what are the yoga exercises that will strengthen back the pelvic muscles so that all these problems will not come? They are called Kegel's exercises, weight loss. And last resort is to put pessaries. So this is the bladder, doctor, and this is the pubic bone, and this is the uterus and the vagina. Between the bladder and urethra, you have the uretrovesical angle. If that angle is destroyed, that lead to the leakage. So that you can be able to re-establish that uretrovesical angle by using the tape. You'll put a tape at the uretrovesical angle and then you'll pull it and then create that the angle is what you need to. You can put it retropubically. You can position the tape in order to restore the uretrovesical angle. Then urgent continence. Here the detrusor is having overactivity that is causing the leakage, and commonly it is due to cystitis like urinary tract infection. Here also Kegel's exercise, bladder training, that is called timed voiding. Ask the patient to bear that urge a little longer. Distraction, relaxation techniques, all these are used in order to overcome. Lastly, you weaken the bladder muscle, detrusor. Cholinergic strengthens bladder, anticholinergic weakens the bladder. Because that bladder is spasmodic, no? So you give oxybutynin to treat the overactive bladder. And you remember anticholinergic drugs. Mirabegron. Are you there when we were discussing pharmacology, anticholinergics and all? No problem. All the videos are available. Mirabegron is used to treat the urgency incontinence, is what you need to remember. Now comes overflow incontinence. Whenever there is any detrus or underactivity or outlet obstruction, incomplete emptying that lead to overflow incontinence with the leakage after the overfilling. So, when do you get this? Normally, the amount of urine formed is normal, okay. But diabetic individuals have polyuria, more urine produced beyond the capacity of 1 लीटर वाला बॉटल में 2 लीटर वाला यूरिन डाले तो क्या हो जाता? ओवरफ्लो हो जाएगा. And any bladder outlet obstruction like BPH or spinal cord injury that creates a atonic bladder. So in all these things, the treatment is put a catheter, intermittent catheterization, it's called. Intermittently pass a catheter so that urine will come out. Because bladder doesn't have the significant tone. Intermittent catheterization is the treatment of overflow incontinence. If it is due to BPH, try to give alpha blockers like tasmalosin, etc., etc. Now comes cystitis. Inflammation of the bladder is acute cystitis. How do they present? Suprapubic pain, dysuria, frequency, urgency, etc. High fever and chills will be there. What is the risk factor for the bladder to be infected? Being a woman is a risk factor because woman has a short urethra and sexually active. Similarly, those who have sexual intercourse history, any indwelling catheter is a risk factor. Diabetes, impaired bladder emptying, anything can cause acute cystitis. Most common organism, E. coli. Sexually active young women, Staphylococcus saprophyticus. Similarly, Klebsiella, Proteus mirabilis. If the Proteus mirabilis, then urine will have that ammonia scent. Proteus mirabilis infection may. Because Proteus mirabilis produce urease that will split the urea into ammonia and that cause urine to get the ammonia scent. Typically, how do you identify infection? Very sensitive marker is leukocyte esterase test. Similarly, positive nitrites. Detection of positive nitrites and positive leukocyte esterase test is a way to identify this E. coli. Sometimes there are WBC in the urine, but all your urine cultures are negative. That's called sterile pyuria. WBCs are there, but urine is culture negative. That typically occur if it is Neisseria gonorrhea or Chlamydia trachomatis leading to cystitis, then you may get sterile pyuria. So how do you treat, doctor? We give primethoprim, sulfamethoxazole, nitrofurantoin. They're all the common antibiotics. Then comes pyelonephritis. Cystitis is over. Then comes pyelonephritis. That means kidney, calluses, proper infection of the kidney. Okay? So in this, what will happen? Neutrophils infiltrate the entire renal interstitial tissue. Glomerulus interstitium is there, no full neutrophils will come and affect it. And they affect the cortex. Glomeruli and vessels are spared. Cortex, renal cortex is there, no, that get affected. They present with fever, flank pain. That is the costovertebral angle tenderness will be there. That's called Murphy's punch. You press on the costovertebral angle, pain will be there. That is called costovertebral angle tenderness is a feature of acute pyelonephritis. Nausea, vomiting, chills, etc. E. coli is the most common organism once more for acute pyelonephritis, and it is often a ascending UTI. That means from the blood to the kidney. No. It is from urethra, bladder or ureter. Through that it starts ascending up is most common. Hematogenous spread also can occur but not most common. Pyelonephritis will lead to WBC CAS in the urine. And in the CT you can see that parenchyma of the kidney, it will show striated enhancements, like striated enhancements of the parenchyma is what you will see. What are the risk factors? Why do you get pyelonephritis? Why kidney is infected? Who made the kidney infected? We made, because we passed the indwelling urinary catheter without a proper washing of our hand. Our hand got patient's pyelonephritis, indwelling catheter. Urinary tract obstruction, vesico-ureteric reflux, diabetes, pregnancy itself, because pregnancy में progesterone होता है. The progesterone will cause a decreased tone of the ureteric tone, not uterine. Ureter become very slacky, so reflux will increase. And there is a compression of the ureter by gravid uterus. That also is a predisposing factor. Once it is compressed, the ureter, then there is a greater chance of obstruction, and all the organism will get pent up in the kidney, leading to pyelonephritis. Acute can become chronic pyelonephritis. It can lead to renal papillary necrosis. You have got papillae in the kidney. So kidney has a cortex, kidney has a medulla, kidney has a glomerulus, kidney has a interstitium, kidney has a papillae, kidney has a tubules. But only a few things kidney has. Be happy. Huh? So renal papillary necrosis. Typically your calyces will show papillae. Papillary necrosis. Around the kidney, in that capsule, there is an abscess, and that can spread to the adjacent psoas, that perinephric abscess. Right? If there is a psoas abscess, what will happen? Psoas is responsible for what? Your flexion of the hip. So when the psoas abscess is there, psoas will go into spasm and patient will go with the hip into flexion. He can't be able to extend his hip. That is a sign of psoas abscess. Then there can be urosepsis, whole body spread, and death. So always, doctor, these UTIs, pneumonias, two things. Bomb it with antibiotics. Elderly man, why does he die? Pneumonia. Elderly grandma, why did she die? UTI. Two things, doctor. If you don't bomb them, they are sure to take the patient to Yamadharmaraja. Morning only patient will be nicely talking. Afternoon he'll get chills, and by evening he will have sepsis. By next day morning, when you come back to the rounds, he is already packed and ready to go, unless you bomb it. So what you are seeing here, doctor, this is the kidney which has developed pyelonephritis. And here you have done the ultrasound, and typically around the kidney, all that inflammation can be identified on the ultrasound also, pyelonephritis. So here what you see, neutrophilic bombardment and infiltration directly into kidney, into the tubules, interstitium, in the case of acute pyelonephritis is what you need to remember. I'm so happy to see 22 online students. Maybe they can another 10 runs, we are done. Okay, just bear with me. Then comes chronic pyelonephritis. Any recurrent attacks of acute pyelonephritis or inadequately treated pyelonephritis. For an adult patient, you give a pediatric dosage of drug. That can lead to inadequate treatment. That can lead to chronic pyelonephritis. Typically, it is a vesico-ureteric reflux. Unless you treat the reflux recurrently, there will be pyelonephritic episodes. Or any chronically obstructing kidney stones also will cause chronic recurrent pyelonephritis. Then this recurrent pyelonephritis will lead to the scarring of the corticomedullary tissue. And the calyces become blunted and the tubules contain eosinophilic casts which resemble thyroid tissue. Eosinophil staining is there, no? Eosinophilic casts that look like the thyroxine in the thyroid tissue. That's what the tubules will show that appearance. That's called thyroidization of the kidney, which you see in chronic pyelonephritis. So this is what, doctor, you need to know. All this eosinophilic material you are able to see inside the tubules. And lot of tubular inflammation is also there. And what is this called as? Thyroidization of the kidney is the feature you see in chronic pyelonephritis is what you need to remember. Then comes xanthogranulomatous pyelonephritis. It is very rare. Grossly orange colored nodules that mimic the tumor nodules appear in the kidney. That's the reason it's called xanthogranulomas. And widespread kidney damage with a granulomatous tissue which is containing foamy macrophages characterize the xanthogranulomatous pyelonephritis. It is the Proteus infection which is responsible for it. So this is a typical, can you see the nodules, doctor? This kind of orange colored nodules if you do gross appearance. This is the typical appearance of a xanthogranulomatous pyelonephritis. Organism is Proteus infection leads to it, is what you need to understand. Now comes acute kidney injury. मेरे प्यारे भारतवासियों, हम बहुत मजे में पढ़ लिया 3 घंटे. Acute kidney injury require a little fresh sitting. Okay, कल बैठेंगे, right? कैसा भी after the class also once more I come back like a devil on the WhatsApp group, keep posting questions. मैं छोड़ूंगा नहीं आपको, जब तक आपको सीट मिलेगा. Whether 25-year-old you guys, 49-year-old Murli Bharadwaj, it's a competition. Who has more stamina to do revision for the NEET PG? After all, what is the job of a teacher, doctor? To inspire you to read more than to teach you to learn. You yourself are very brilliant minds. You anyway will learn. So thank you very much to everyone for joining. Tomorrow, we will sit for another 3 hours and finish.